So welcome everybody. My name's Donna Sporandio and I work here at Medell as Head of Rehabilitation. So for today's presentation I'm going to give you an overview of the process post-implantation. Who does well and why? So we're going to look at the factors and the processes that affect outcomes post-implantation. Here's an overview of the content. First of all, we'll look at the factors that affect outcomes. We'll give an overview of hearing loss and neural development, and then look at intervention and some key considerations that we need to be thinking of. So first of all, let's look at the factors that affect outcomes post-implantation. So who do we consider a candidate for a cochlear implant? Well, of course, the age range varies from country to country. But typically we're implanting a very wide range of candidates, from quite young babies right through to the elderly. So this graphic shows a range of outcomes in children, because we know that post-implantation we do see a range of outcomes. At the top of this graph you will see spoken language equivalent to hearing peers. And that's really, if you like, the gold standard that we're all looking for post-implant. This is a child who, having received their implant, ends up with spoken language exactly the same as a child of the same age. So these children look and sound exactly like their peers who have normal hearing. But of course we know that that is not the case for every child who is implanted. So this graphic shows that range of outcomes. It might be simply that a child has an increased ability in spoken language. It might be, as we see here, what we call spoken language equivalent to hearing age. So the hearing age is the number of years that a child has received a cochlear implant. So if a child has a chronological age of 4 years, but received their cochlear implant at the age of 3 years, then their hearing age is 1 year. So an outcome might be that their spoken language is the same as their hearing age. So in this case, the child would have a spoken language of 1 year. For some children, we see this as an aid to speech reading and literacy. So that by speech reading, I mean the lip reading pieces and the reading of the body. So a cochlear implant can give great information that can assist in speech reading. In literacy development, we know that access to spoken language, access to the sound of spoken language can improve literacy outcomes. Now you'll see down here towards the bottom of this graphic, we talk about environmental sound awareness. In 2017, we're implanting many children around the world who have additional disabilities. And some of those children have quite profound and multiple disabilities. So it might be for those children that the understanding of sound and the environment around them is the level of outcome that they achieve. But that can still be a really, really worthwhile outcome for those children. That might help them in aspects of safety, it helps them to be more socially aware, it helps them to know that their family's in the room with them. So in many countries around the world now, that's considered an acceptable outcome. At the bottom of the graphic, you'll see here that we have put no change. It's very, very rare, particularly in today's world, but very occasionally, for some reason, a child might not actually get a perception of sound from their cochlear implant. So it's important that we acknowledge that, even though that's a very, very rare outcome. So what does that graphic look like if we talk about older recipients and adults? Well, at the top of the graphic, the kind of gold standard, if you like, the ability to converse easily, including in noisy situations and on the telephone. That's really our gold standard when it comes to our older recipients. But of course that's not possible for everybody either, so this graphic shows the different level of outcomes. For some recipients, it might be the ability to converse easily where it's quiet. Again, it could be an increased ability to speech read. Some adults manage to improve their vocal tone post-implant. So we know that for some people who have had a long-standing hearing loss, sometimes the tone of their voice is affected in a negative way. So once a person has a much better access to sound through a cochlear implant, this can be improved with rehabilitation. And again, towards the bottom of the graphic there, you see environmental sound awareness. Again, around the world in different countries, we are implanting adults who have significant other disabilities. So this may be the level of their achievement post-implant. And again, we recognise on the bottom there that for a very, very small number, there might be no change in their perception of sound. So we've talked about the range of outcomes that we see in our recipients. But then the question is, why is it that some of those recipients end up at the top of that list, whereas others have a more compromised outcome? So let's look at some of the factors that we know affect those outcomes. So we're going to split these up into intrinsic factors. Those are the pieces within the person that are sometimes outside our influence, and extrinsic factors, the pieces outside the person. So let's talk about children first and look at their intrinsic factors. So here's a list of them, and we're going to go into each one in a little bit more detail. So first of all, the age of optimal amplification. This is a really, really key factor that we know makes a big difference in the child's outcome. And we talk about the provision of optimal amplification. For some children who have a progressive hearing loss, they may have had optimal amplification through hearing aids in their early years and then needing a cochlear implant later. But for many children who are born deaf, we know that that time of optimal amplification comes only when the child is implanted. So what are the pieces we need to be thinking of in order to get this age as early as possible for our recipients? First of all, of course, newborn hearing screening is a big part of this picture. In countries where there is newborn hearing screening, we have the opportunity to move towards early aiding and early cochlear implantation. We do know, and as professionals working in the field, we must be aware and advocate for the fact that children implanted earlier will generally have better outcomes. In the rehabilitation process, we need to be ensuring that we constantly monitor the child's functional access to sound. And by that, I mean their ability to perceive all the sounds across the speech spectrum. So it's really important that we're monitoring constantly those children, particularly those using hearing aids, to ensure that they are getting the best access that they need and that they are referred for a cochlear implant as early as they should be, if that's indicated. Whether a child is pre or post-lingually deafened can make a difference. Really, if a child is post-lingually deafened, then we know that they had an intact auditory system and an intact language system pre-implant. So that system was there and it was built ready to receive the sound from a cochlear implant. A child who's pre-lingually deafened can still have an excellent outcome. It is, however, dependent on the age at which they received their implant, as we discussed previously. Medical findings can make a difference to outcomes. So it's important that there is an understanding pre-implant of the status of the auditory system. For example, if there's a compromised or thin auditory nerve, that can make a difference to outcomes. Auditory neuropathy spectrum disorder is a now well-known etiology of hearing loss, and for those children we know that there can be also a range of outcomes post-implant. The etiology, the cause of the hearing loss, can give us some clues as to what the outcome might be for a particular child. And I've just put a small number of examples on this slide. So for example, connexin 26 is a very common genetic cause of hearing loss. And for those children, very often they are only deaf, so that deaf is their only, the only piece that they're dealing with. And often those children will do quite well if they're implanted early enough. Other causes of hearing loss can be things like cytomegalovirus. It can be a syndromic cause, so that there is other disabilities present with the child, and then we might expect a somewhat lower outcome. So the cause of hearing loss can give us some clues as to what the outcome might be. Of course, non-verbal intelligence might come into the mix. Some programs around the world do assess non-verbal intelligence as part of their pre-implant workup, but some don't. But we do see that for some children, it seems that their non-verbal intelligence can make a difference to their outcome post-implant. The presence of additional disabilities has been shown to often lower the eventual outcome for a child post-implant. So the presence of oromotor difficulties, for example, might impact on the child's ability to make all the sounds of speech expressively. A cognitive delay can have an impact, as we've already mentioned. Things like visual difficulties or sensory integration difficulties can also impact on the child's ability to perform with a cochlear implant. Communicative intent is something which we need to be thinking about, particularly from a rehabilitation perspective in the development of listening and spoken language. Some children are simply born with more of an intent to communicate with others. However, it can be that simply a lack of experience, so if a child hasn't had good amplification, hasn't had the ability to have lovely communicative interactions with those around them, that can reduce their communicative intent. It can reduce their desire to be part of the communicating world. And so those are factors that can sometimes affect outcomes in children. We do know that a significant number of children who are implanted now do fall onto the autistic spectrum. And for those children, their outcome may be affected. So we've talked about some of those intrinsic factors, factors that are within the child before they come to implantation. But now I'd like to talk a little bit more about the extrinsic factors, the factors around the child. So let's look at some of those in detail. First of all, compliance with amplification. We know that it's very, very important that children wear their devices all the time. This is a key to good outcomes. The audio processor should be worn all waking hours from the time of switch on. So we sometimes say to parents, if the child's eyes are open, the processor should be on. Of course, we would recommend that children take their processors off while they're asleep. But if the child's eyes are open and they're awake, then we want those processors on so that we can start building an auditory system. A real key to good outcomes. Then the educational program that the child is in. If we want a child to learn spoken language, then we know that the best way to do that is through a program that emphasises listening and spoken language. Children need exposure to language in quantity and quality by sophisticated users of the language. So the type of educational program the child's involved with, we know can make a difference to their outcome. The child's behaviour. Some children are simply easier to manage than others. Some of them will sit nicely while they're involved in the fitting process or while they're involved in rehabilitation games, and others find that more of a challenge. But this is really, for us as professionals, something that we need to think about and manage. Some children simply will need more support to get to the same place as others. We know that the dynamics of the family is a key indicator to outcomes post-implant. Over and over again, we see that the maternal level of education has been shown to be a factor in outcomes. Why is it that parents who are well educated sometimes do better for their children? Well, it's probably around their ability to search for information that they need, the ability to follow through on the educational program that's provided, the ability to advocate for what their child needs. So as for those of us involved in rehabilitation, there's a key message in there for us that says we need to try and deliver those skills to all of the families we work with. Some of our families come to us with those excellent family dynamics where there's a high level of education and families are able to manage everything we ask of them. But for those families for whom that's not the case, we need to put lots of energy into family-centred intervention so that we can raise the skills of those parents too. So what about those factors when it comes to adults? Well, really they're similar. So the intrinsic factors within the adult include things like duration of deafness. Medical findings, again, the cause of the hearing loss, again, can give us a clue. Some adults are implanted who have additional disabilities. There are two extra things that we need to be thinking about, though, specifically for our adult population of recipients. First of all, mental health issues. So we do know that in the population of adults with significant hearing loss, there is a higher level of mental health issues. So we need to be thinking about that when we meet our recipients pre-implant. We also need to be thinking about cognitive function. It's recently been very clearly shown that there is a correlation between, there is an independent association between hearing loss and cognitive function. So that cognitive function is at risk of decline as hearing declines. So it's very important that we're aware of that we know that the cognitive function of an adult is also a factor that might influence their final outcome post-implantation. What about the extrinsic factors around adults? Again, compliance with amplification. They need to wear the device. They need to be committed to practice. They need a significant rehabilitation process, and they need to be committed to be part of that. They need to spend some time really actively listening with their device. Again, family dynamics can make a difference. If you think, for example, of perhaps an elderly lady who might be implanted, she might be living in an apartment where she's by herself for most of the day. And in that situation, she doesn't have a lot of chances to interact with others. She doesn't have a lot of chances to hear spoken language and to improve post-implant. So we need to be thinking about family dynamics and social situation as part of the process with adults as well. Now, in all of these factors that I've spoken about, we're not talking about these as factors that say yes or no to a cochlear implant for that person. No, that's not what I mean. What I'm talking about here is that every recipient comes to us with a different range of these factors, and so we need to be aware of those factors and aware of the outcomes that might come post-implant. But typically around the world, these are not reasons for us to say no to a cochlear implant. That's not what I'm meaning. Instead, these are factors that we should know about pre-implant and should think about when we design a rehabilitation process for our recipients. So let's look briefly at hearing loss and neural development. So what can a cochlear implant do? Well, it restores a sense of hearing. And that allows access to the sounds of speech and access to the sounds of music. But then the question is, what can't a cochlear implant do? Well, at the moment, it doesn't restore normal hearing. We've certainly got fabulous engineers here at Medell working very hard to make the signal the best we can, but we can't yet restore normal hearing to our recipients. And the other thing that we can't do is to make up for lost time. So let's look at that in a little bit more detail. Let's talk about the auditory system. So the auditory system is also developed both intrinsically and extrinsically. There are peripheral hearing structures that capture and send speech and acoustic information to nerve impulses, which then transmit these to the brain. It's what's happening in this brain, in the auditory system in the brain, that matters. So let's talk about the intrinsic piece of the development of the auditory system. A baby is born with auditory pathways and neural structures sitting there ready to receive sound. That's a consequence of typical biological development. The working connections need to be there in order for learning to take place. Then extrinsic development begins. This is driven by stimuli. And this occurs when the sensory pathways are activated by the relevant stimuli. So we have this baby there ready to receive sound, and if that sound comes into the brain, then the system is further developed. So early in life, the neurons begin to form connections or synapses in existing neural structures. But for children with hearing loss, when that sound doesn't arrive to the brain, there is a period of auditory brain deprivation. So that a baby with hearing loss is not starting from the same neurological point as a child with typical hearing. That time of auditory brain deprivation is what we're referring to when we talk about lost time. Let's look at that in regards to a child. So here is a child, her name's Reiwa. Reiwa had a profound hearing loss, which was diagnosed shortly after her birth. At this point in time, her chronological age is 3 years. And the age at which her cochlear implant was activated was 2 years. So her hearing age is 1 year. Now, how long has Reiwa had of that period of auditory brain deprivation when her brain has reorganized itself? That's a time frame of 2 years, which is 730 days, which is 17,520 hours. So as you can see, there's really quite a lot of lost time, even if we can implant a child at the age of 2 years. What does that look like for an adult? Well, here's Andreas. Andreas is 70 years of age, and he was implanted at the age of 65 years after he had a progressive hearing loss that began in his early 20s. What does that look like for him? Well, that's a much more difficult question to answer, really. Firstly, Andreas had a time in his early life in which his auditory system was fully developed. So there was that time for that to happen. But he's had a progressive hearing loss over many, many years. So there will be at least some reorganization of his brain following that auditory deprivation time. But for an adult like Andreas, it's much harder to be exact about what those figures look like. Let's talk a little bit about neuroplasticity. This is the brain's ability to change its structure and function in response to input from the environment. Brains change themselves. How does that change occur? Well, specific parts of the brain respond in particular ways. The brain is a dynamic and active system, and actually it keeps rewiring itself right throughout our lifetime. And it rewires itself according to the experiences that it encounters. As we've said, a baby's brain, however, if there is a period of auditory deprivation, develops differently. A baby's brain will gradually eliminate the synapses that are not being used in order to operate more efficiently. So if sound stimulation to the brain doesn't occur, neural structures begin to reorganize themselves. We know that the areas specifically designed for auditory input are taken over by other senses, particularly the senses of vision and touch. And we call that cross-modal processing, organization, or reassignment. Let's talk about sensitive periods now. A sensitive period is a window within which the potential for neuroplasticity reaches a maximum. So we've said that the brain changes and reorganizes itself right throughout our lifetime. But there are some times in which there is a sensitive period when the potential for that neuroplasticity is at its highest. So if proper auditory stimulation is not provided in a timely fashion, there can be a disconnect between areas of the brain which connect sound with meaning, and areas of the auditory cortex will reorganize themselves to process stimuli from other sensory modalities. So how might we measure this? We're going to look briefly at what we call a cortical auditory evoked potential. This measurement reflects electroencephalography activity in response to the stimulation by sound. And this can be recorded non-invasively from all the levels of the auditory pathway. As we said, it's non-invasive. You can see that this little baby's quite happy having this procedure done. So on this graph you will see the entire waveform that has been recorded in response to a sound stimulus. Down the bottom of this picture you see the auditory system, the entire auditory system through the brain, laid out in a flat way. So from the very early pieces there you see where the outer hair cells are stimulated, the early stimulation of the cochlea, right through the entire auditory system in the brain. And you can see that there are various peaks in that waveform which correspond to areas in the auditory system. So we're going to look a little bit more specifically now at the first peak that we call P1. So on this graph you see a small piece, the first piece of that brainwave has been chopped off, and that's what we're looking at. Along this axis we see time in milliseconds. So how long does it take for that first peak to appear? So what does this show us? The P1 is that first positive peak of the response. In children, that first peak happens between 100 and 300 milliseconds. The time it takes for that peak to appear represents synaptic delays along the auditory pathway. So what we're saying is the quicker the response, the stronger the auditory pathway. So the amount of time it takes for that peak to occur can be used as a measure to look at auditory development, and that's what researchers have done. So the faster that peak appears, an indication of the stronger auditory system. So this graph shows what that looks like in typically developing, typically hearing children. So along this axis you see age in years, and up this axis you see the time, the latency, the time it takes for that first peak to happen. And you can see in this graph that very quickly the time taken drops. Very quickly this auditory system matures and that latency response gets faster and stronger. But you can also see that there is still some changes that occur. It keeps getting faster right through into the teenage years. So then researchers said, well, what does that look like for children who receive cochlear implants at different ages? So on this graph, again, we have age along this axis, and we have latency, or the time for that response to appear, on this axis. These black lines have been directly transferred from what was found from normally hearing children. So in this graph, the dots that you see in red are children who were implanted before the ages of 3.5 years. Those in blue were implanted between 3.5 and 6.5 years. And those in green were implanted over the age of 7 years, with these children having been born deaf. So what you see here is a very clear indication that those children in red, those children who are implanted before the age of 3.5 years, are able to fall into the typical typical result for that P1 latency, that indicator of auditory development. Some of the children implanted between the age of 3.5 and 6.5 fell into that, were able to get into that normal curve, but almost none of the children implanted over the age of 7 years. Here are those two graphs side by side. So you can see there very clearly, again in the graph on the right, that the children implanted before the age of 3.5 were able to get responses that fell into the normal range. Please remember though that this P1 response is really just a very raw response that we're measuring. That doesn't necessarily guarantee that those children will develop listening and spoken language in a typical way, and it also doesn't guarantee that the children who don't fall into the normal range can't make at least some progress in their development of listening and spoken language. This P1 latency is just a very raw first response indicator of the strength of the auditory system. So this pivotal research is showing us that there is a sensitive period. We talked about the brain changing. We've said that there are some times in life in which that brain changes more easily for various aspects of development. So this is showing us that there is a sensitive period of approximately the first 3.5 years when the human central auditory system is at its most plastic. So that is really the science behind that conclusion that we drew earlier, that age is one of the key indicators when it comes to outcomes post-implant. And as professionals working in the field, we need to take this information and advocate for children to receive cochlear implants as early as possible when they're indicated. But this research also showed that there is some plasticity that continues in some children until around about the age of 7 years. So, some key considerations for intervention. All of what I've said so far really summarises this auditory stimulation. Actually, we hear with our brains, and the ears are just the way into the brain. It's the brain that's the important part when it comes to rehabilitation and intervention post-hearing loss. How can we maximise the development of skills with auditory stimulation? Well, first of all, we know that the technology alone doesn't guarantee positive progress. We need to be thinking about that wide range of factors that you already know about that affect outcomes. All of those factors go towards the development of positive progress. Individuals need support to use the technology as a modality to learn. We often say that while hearing is a passive sense, listening is an active process. So hearing really just happens to us. We can sit here, we don't need to do anything, and we can hear if we have normal hearing or if we're hearing with technology. But the listening process, how we manage that hearing, how we attend to different stimuli, how we learn what those stimuli might mean, that is an active process. So in rehabilitation, we work very much in that listening process because that's an active thing that we can teach and we can improve. Having looked at all those factors that affect outcomes, we can say that individual intervention programs need to be tailored to the individual needs of each child, family, or adult. Intervention programs should follow developmental guidelines, and clearly active participation in intervention programs is necessary. In intervention programs for children, we recommend the active participation of the families of the children. And for adults who receive cochlear implants, they need to be actively participating in intervention programs, and where possible, their family also should be involved. Having looked at all those factors that affect outcomes, you can see that the process pre-implant is of paramount importance. So we recommend that there is a process of anticipatory counselling that happens for recipients and for recipients' families in that pre-implant time. It's appropriate for you to discuss with recipients and their families, discuss the range of factors that affect outcomes. You can look at each of those factors in respect to the individual that you have in front of you who's considering a cochlear implant. We want to ensure that families of children and adults receiving implants have appropriate expectations of what the outcome might be. And we believe that setting that scene really well, giving lots of that information to families and to recipients pre-implant, that process sets up the situation for best success. So we believe that the anticipatory counselling process is very important. As I said, we want to set appropriate expectations of what might happen for that individual. But of course, we also want to have high expectations. We know that every individual who comes to us will have a different outcome. So we want people to be appropriate in what they expect, but we also want them to push for a good outcome, to be really actively involved in intervention to ensure that the highest outcome possible can happen for the recipient. So thank you for spending time with me talking and thinking about this process. I hope that that's a helpful introduction to the rehabilitation process and how we suggest that you manage it. And we look forward to sharing some more thoughts on the rehabilitation process over the next few presentations. Thanks for your time.